Dr. Zheng Hua, who is an anesthesiologist from Tongji Hospital in Wuhan, which is one of the best hospitals in China. Thank you so much for joining us, Dr. Zheng.
Thank you.
Dr. Zheng has been battling the coronavirus in Wuhan for months. He is going to join a webinar on COVID-19 treatment with his European counterparts, who are also from the Department of Anesthesiology. Well, Dr. Zheng, I have a question before your meeting. Could you introduce a little bit about your daily work in the isolation wards?
Okay. Since the outbreak of COVID-19, about 100 operating have been performed in our hospital, and over 200 emergency intubation had been conducted in our hospital. So today I would like to share our lessons and experience with our Europe colleagues.
Because we've heard a lot of experiences from the doctors of the Department of Infectious Diseases or Respiratory Diseases. You are the first doctor from your department. Could you introduce the importance of your department in the treatment of COVID-19 patients?
Now, about 70% patients in the intensive care unit is intubated. So the intubation was performed by anesthesiologists, and emergency surgery received a different kind of anesthesia. All of this kind of anesthesia were performed by anesthesiologists. So I think the anesthesiologists play a very important role in the struggle of COVID-19.
So today, CDT is going to live broadcast Dr. Zheng and his European peers' professional discussion on the treatment of COVID-19 patients. You can watch this live stream on our CDTN app and also YouTube, Facebook, Twitter, and Sina Weibo channels. Please feel free to leave your questions in the comments section. And also you can use the hashtag #MyOpinionOnCovid-19 on these channels. And I will be back after Dr. Zheng and his peers' discussion with your questions, and Dr. Zheng will answer the questions by the end of the live stream. So now I will leave the stage and hand it over to Dr. Zheng and the host of today's webinar. And please stay tuned. I'll be back with your questions.
Thank you.
So now we can turn on the volume of the webinar. So it is the first time you join this kind of webinar?
No, actually I have joined a lot of webinars with this professor from Germany about this topic, and I think it's very important to share our lessons and experience. So he hosted this webinar with me and other colleagues from Italy, from Hungary, and from other countries in Europe.
Yeah, we know that Chinese doctors, especially doctors in Wuhan like you, have been fighting against the coronavirus for the longest time in the world. So do you think Chinese experiences or your experiences are useful for other doctors in other countries?
Yeah, I agree, because the situation now in Europe is similar to the situation at the beginning of outbreak of COVID-19 in Wuhan. So I think our lessons and experience can help them to deal with the patients better.
So in the future, are you going to have more this kind of webinar with doctors from other countries?
Yeah, I got my doctorate degree in Germany, and my director is discussed with me to host a lot webinar about COVID-19, and my postdoc director is in the US. He will also want to organize such kind of webinar with Chinese colleagues.
So what are you going to present? Do you have a topic of your own presentation? Could you introduce to our audiences a little bit?
the presentation topic is about perioperative management and emergency and trachea intubation of patients with COVID-19.
Okay, thank you so much.
Thank you.
Okay. So we can leave you the stage and start your webinar.
Okay, thank you.
For our audiences, the webinar is going to start at any minute. There are still some minor technical issues. For our audiences, this is our 10th online consultation worldwide. We invited Chinese medical workers and also experts from the China's coronavirus epicenter, Wuhan city, to share their first-hand experiences with their global peers. Well, in the future, after this one, we will invite more doctors from different departments to share their experiences in the hope of sharing more information for those who are still fighting against
everybody.
the coronavirus.
So we are together here to discuss the issue of the COVID-19 pandemic and which are the implications that we for anesthesiologists, for intensive caregivers, and all other caregivers who work in this area. It's my pleasure here to have some experts from Italy and also from China, which are Professor Celia, Dr. Tseng, and Professor Pelusi. We have as the host Professor Bobek from Hungary, to whom I give the word now.
Thank you very much. Good afternoon, everyone. The European Society of these extremely difficult and challenging times of the COVID-19 pandemic. Therefore, this first webinar is organized to learn from and speak to experts from those countries with the most experience during this epidemic. This webinar is sponsored by Multi-Learning Company. I'm Ilona Bobek, an anesthesiologist and intensivist from Budapest, Hungary, where the disease has just started. Today, I'm your host. The scientific faculty leader is Professor Marcelo Gama-de-Abreu from Dresden, Germany, and our experts are Professor Giacomo Grasselli, Professor Hua Zheng from Wuhan, China, and Professor Paolo Pelusi from Turkey. Let's see the figure. Yesterday we passed 1,000 cases of COVID-19. Within 2 days, we have nearly 100,000 more cases. So, let me introduce our first speaker, Professor Giacomo Grasselli. Giacomo, how is the patient Lombardy to the first case?
Show you some slides to explain what happened here in Lombardy, and then unfortunately spread to nearby region with less violence. Let me see if I can. Okay. So first.
We can see Giacomo, no problem.
Yeah,
that is your first slide.
I'm trying to show the second
it's
one.
On. Thank you very much.
Which is this one. And this is telling you what happened before the first case was diagnosed. These are the epidemiological curves can see that in already from, let's say, the first weeks of January, we saw a strange curve, because after the peak of the curve, we didn't see the typical decrease like this every year, but we saw that the curve did not decrease, and we saw even an increase in the curve, meaning that well before the first case of COVID-19 was confirmed, we had a number of cases of so-called flu, or of patients with upper respiratory tract infections and atypical pneumonia that were diagnosed, misdiagnosed with the increase in the number of coronavirus confirmed cases. So this is just to explain that in Lombardy, we had a situation that was probably similar to what happened in Wuhan, that the virus has been circulating in some areas for a certain period of time, having the time to infect a good number of people. Then, when a high number of infected people were grouped in this the market, then the epidemic exploded. So we really had an explosion of cases, which we had to either. So we had an exponential increase in cases. So the first case. The first nose, hospital in the clue was that he had dinner with some the patient one. And despite all the attempts to track his contact and of contact tracing and to isolate the contacts of this guy, we haven't been able to identify a patient zero, and we haven't been able to control the spread of the disease. The day after the first one, we already had almost 40 new positive cases who were not linked to patient one, demonstrating that a huge number of people had been infected by the virus. So we constitute a task force in the government of the region, and me, and Professor Pesenti and Professor Zangrillo were asked to coordinate an ICU network. We had in Lombardy a total number of ICU beds of around 720 as of February 19. Of total hospital beds, and that have a mean occupation rate of 85–90% during the winter season, as like everyone else, everywhere else. And what we thought to organize the response to bed capacity. So we decided to ask to 15 hub hospitals that were from the rest of the hospital and from the rest of the ICU beds. So the first response was to constitute a network of 15 COVID-19 beds. Fast, we basically reduced by 50, then 70, then now almost 90% all elective surgery. And so this, we were able to free, resources, especially human resources. But the amount of patients kept increasing exponentially. So during the second week, in the first 2 weeks, we had like more than 600 patients treated in the ICU. Of them, 80 were still waiting for the confirmation of the diagnosis, but even if you do not take into account them, we have like 556 patients, a total of 556 patients treated in 2 weeks in the ICUs of Lombardy. So we had to increase our network. So now the network is composed of more than 70 dedicated ICUs, and I would say that the majority of the hospitals in Lombardy have become COVID hospitals, because most of the patients admitted to these hospitals, both in the ICU and in the wards, are COVID-19 positive patients. You can see here that the rate of admission of ICU patients, of patients in ICU, is quite high compared, for example, to the numbers we know from China and from other countries. And this can be explained by our decision. Well, it was a forced decision, okay, to test after the first days only patients with more than 40% of the swabs that we take are positive for COVID-19, compared to less than 5% of positive swabs in other countries. So now we are testing only positive. So the high mortality that we have, because the denominator is completely different from other case series. Again, in these slides you can see the increase in the number of patients, and we have been basically to almost double our ICU bed capacity. And and we have also reorganized the hospital network in Lombardy in order to concentrate other diseases, especially time-dependent. Through my in ICUs. So this has been basically our response. We have increased again by now almost 100% our ICU bed capacity, and we have reorganized the entire hospital network. But this might not be enough. And if you look, this is like a model that of ICU beds that we would need, comparing a linear or an exponential increase. And we are now in the middle of this. So is only how our region appears and how density of cases changes from the spread in the entire region. There are 3 areas which are particularly with a particularly high number of cases, which is the region of Lodi and the region of Brescia and Bergamo, as you might know. But unfortunately, in the last 2-3 days, the number of cases here in the region of Milan started to increase, and this can be clearly a big problem. This is how the number of patients and the number of ICU beds increased. And you can see that we started from 34 patients after 3 days from the first diagnosis up to now almost 1,400 patients intubated. Most of them are intubated in our ICU. Actually, not only ICUs. We have now patients in the operative rooms and in emergency departments and wherever we can put an intubated patient. So the total number of patients have been treated in our ICU is 2,349. Of them, almost 400 have been discharged, more than 500 died, and we now have in the ICU, again, almost 1,400 patients. 81% of them are male, a very high number. Most of them are intubated. In the first days, the percentage of intubated patients was like 80%, and it now increased up to 92%. So we're basically admitting to ICU only intubated patients. The rate of prone positioning is certainly underestimated because we do not have complete data for all those patients. And as you can see, the number of ECMO cases is very low. And then if you want, we can discuss this, but also Paolo can say something about this. The median age of our patients is steadily decreasing. We started from 67, and now it's 63, and the mean age is 62. And we are admitted younger and younger patients in the last couple of weeks. This is the age distribution for patients who died, patients who have been discharged, and patients who are currently in the ICU. And the mean PIP level is 12, mean and median PIP level of the first day at ICU admission. Okay. The mean and median PF ratio so we seem to have moderate or moderate severe, relatively high levels of PIP and a high incidence of prone positioning, but I'm sure that Paolo will tell us something about this. And so the messages I wanted to share with you is that first of all, when you are facing an outbreak of COVID-19 disease, you have to expect a huge mismatch between the number of patients requiring ICU admission and your total ICU capacity. This is constant. I mean, everyone who is experiencing this can confirm this. So our response to try to COVID-19 ICUs, and we had a central coordination here from the government of the region in order to try to optimize patient allocation. So at least at the beginning, when we had 3 beds, we were able to allocate the patients according to their severity. Wanted to send the more severe centers with this is much more difficult to do, because now it's very difficult to find a free bed. So whenever we find a free bed, we have to prioritize those patients who are allocated in very, very bad situations. For example, in small hospitals near Bergamo where no ICU is present. Clearly, a problem, an important point to train the healthcare workers on the proper use of personal protective equipment and try to try to have another number show the pandemics. What we do is the treatment patient. For example, in my hospitals, COVID-19 anesthesiologists to take care of them. We have not only nurses with experience in treatment of ICU patients, but we also have anesthesia nurses helping us. And the patient, the doctor to patient, and the nurse to patient ratio clearly is different from the one we had before this happened. So the quality of care is, how can I say, probably lower than before. And so what we decide is try to protocolize treatment in order to have, an homogeneous treatment protocol for all the patients.
Thank you, Giacomo. Thank you very much. I guess, Marcelo, you have some questions from the audience. You are busy with them?
I do have some questions. The first ones, of course, to Professor Grasselli. Professor Grasselli, do you know, are you aware of any case of reinfection? So one of the participants is asking if reinfection is possible.
Yeah. I know that it has been described, at least in a couple of cases, not here in Lombardy. I think we are not at that point yet. But I know it's been described. And I know that in some places here in Italy, they're trying to study the immune response to the virus. I'm personally, I have no direct experience of reinfection. I know it's been reported that it can occur.
Thank you very much. Thank you, Marcelo, and the audience. During the outbreak of COVID-19, what are the main risk factors of cross-contamination for healthcare workers in the Department of Anesthesiology?
Currently about... Yes, currently about 81,000 cases have been reported in China. Among them, more than 3,000 are healthcare workers. The risk of healthcare workers, the risk of getting COVID-19 for healthcare workers is greater than that of general population. And I think anesthesiologists have even higher risk of getting COVID-19 because anesthesiologists manage airway and ventilation in clinic practice. For example, the intubation, extubation, ventilation, CPR, etc. are all high-risk procedures. So it's extremely important for anesthesiologists to follow strict self-protection precautions.
I see. And what is it safe to conduct the routine anesthesia induction in the non-suspected patients? Will you talk about how to deal with patients undergoing emergency surgery without COVID-19 screening?
Based on current epidemiological data, the incubation period ranges from 1 to 14 days. Because some patients still in incubation period without clinical manifestations, standard protection should be conducted when performing anesthesia in non-suspected cases. In fact, some of colleagues in Wuhan get infected when they perform anesthesia in non-suspected patients. So for the risk of early emergency surgery is much higher than that of elective surgery. Before entering the operating room, a triage should be performed by anesthesiologist, including reviewing the medical history, a brief physical examination, reviewing the chest CT scans or X-ray. If the COVID-19 is confirmed or suspected, the patients should be placed in isolation holding area and transferred to operating room dedicated for patients with COVID-19.
I see. And can you talk us about the cases when suspected or confirmed virus positive patients in the operating room, how to protect the personnel in an emergency operation case, and how the anesthesiologist can protect themselves during the intubation?
For suspected or confirmed patients, the highest level of protection should be conducted. The operation for such kind of patients should be performed in an operating room with negative pressure system. If there is low negative pressure system, the positive pressure system or air condition should be turned off during the operation. And the door of the operation room need to be marked as infection surgery to prevent unrelated people from entering or leaving the operating room. All of the medical personnel involved in the operating room should wear N95 mask, the whole body gown, protective gown, the goggles and the face shield, 2 layers of gloves and foot covers. If the patient is a normal airway, a rapid sequence induction can be performed with sufficient muscle relaxation. And during pre-oxygenation, 2 layers of white gauze can be used to cover the mouth and the nose of the patients to reduce the risk of aerosol production. During the extubation, the 2 layers of white gauze can also be used.
I see. And what's your anesthesia should be used for patients with suspected COVID-19? And we were talking a little bit about also intubation.
In my opinion, general anesthesia is recommended for patients with COVID-19 to reduce patients' coughing during intubation, because coughing will increase the risk of aerosol or droplets production. Other types of anesthesia can also be selected depending on the type of surgery and patients and the individual patient's need. For C-cell section, this is a special operation. Spinal anesthesia is recommended as primary choice for C-cell section in mother with COVID-19 because since the outbreak of COVID-19 in Wuhan, over 19 C-cell sections have been performed in our hospital. Most of them receive spinal anesthesia. And general anesthesia should be prepared as a backup for C-cell section.
And the difficult airways, do you have any method?
Here I want to mention the intubation should be performed by experienced anesthesiologists to minimize the intubation attempt because the intubation attempt will increase the risk to exposure. For patients with anticipated difficult airway, oral fiber optic or video laryngoscopy intubation is recommended because these two methods can significantly increase the distance between the airway of patients and the airway of anesthesiologists who perform the intubation.
I see. And Hua, do you talk about the possible protective pulmonary ventilation strategy during general anesthesia?
Protective pulmonary
Ventilation.
Yeah, ventilation strategies include a lower wide volume of 6 to 8 milliliter per kilogram, pledge airway pressure less than 30 centimeter of water pressure. A long recruitment maneuver 3 to 5 times an hour and appropriate fraction of inspired oxygen.
I see. And there is also a very important question that what is the indication of intubation a COVID-19 patient out of the operating room?
Our criteria for intubation in the patients with COVID-19 include AIDS with respiratory rate greater than 30 per minute, the oxygenation index less than 150 milliliter of mercury, or hypocarbic respiratory failure, or low improvement of 2 hours of high flow oxygen therapy, or other method of non-invasive method of ventilation, or loss of consciousness.
I see. Well, thank you very much. And Marcelo, let's check the audience question.
Well, we have a lot of questions, I think. Well, so how should we treat and consider the patients that are not asymptomatic in these times, so they are not tested positively for COVID-19, but still they have to undergo surgery under general anesthesia? What's the recommendation from you to deal with those patients?
For those kind of patients, if it's possible, it's recommended to perform CT scans, the PCR test, the test of antibodies of coronavirus in blood, if the patient's if the surgery is emergency, we have no time to perform such kind of test. In my opinion, the standard protection should be conducted. Otherwise, in the case the patients in the incubation period, the anesthesiology or other healthcare workers will be at higher risk of infected.
Okay. Another question that is very important from the audience is, once the patient is intubated, so which are the risks that we still have for the anesthesiologists and all for the surgery team?
You mean when we perform intubation, which risk do we have to be infected?
Yes. The risk after intubation is considerably reduced because the patient now is connected to the device, to the ventilator, or the risk is still high for the team.
Yeah. For the team, all of the healthcare workers involved in intubation should wear proper personal protective equipment. Here I would like to mention, after intubation, the anesthesiologists who perform the intubation need to remove the outer gloves immediately after completion of intubation and replace a new one. The removing of personal protective equipment need to be slowly and appropriately, because remove personal protective equipment is much dangerous than wearing the protective equipment. And the hand hygiene must be performed between each step of removing personal protective equipment, and a whole body shower is highly recommended after we removing the personal protective equipment.
Okay. Another question that is very important, we talk always about endotracheal intubation, but one person from the audience is asking about the use of supraglottic devices to secure the airway. Are they as safe as endotracheal intubation in terms of protection of the team from infection? As
I have mentioned, the laryngoscope intubation is the most method we use here in our hospital. And when it's not difficult to ventilate with mask, we can also prepare a intubation laryngeal mask before intubation. That means first we put a laryngeal mask, then we use muscle relaxation, and finally we intubation through this mask.
So much. There is one maybe the last question to you regarding extubation. So of the patient who has undergone surgery. So where to do this? How to do this? What should be taken care of?
It's recommended the patients with COVID-19 should be sent to the isolation room in intensive care unit after surgery. But if the patient is stable, extubation can be performed in operating room. Before extubation, 2 layers of white gauze can be used to cover the mouth and nose of the patient. a closed suction system need to be used. If there is low closed suction system, we need to minimize and make only the necessary sections. And after extubation, all the nurse and anesthesiologists need to wear personal protective equipment during transfer, I mean outside the operating room.
Thank you, Hua, and thanks our audience. Don't forget you can keep sending us questions. And now, Paolo, may I ask you, is there any role of non-invasive respiratory support during triage?
Do you hear me?
Yes, excellent. So I had my first question to you. Is there any role of non-invasive respiratory support during triage?
Do you hear me?
Yes, we
Yes,
do. Maybe there
we
are
do.
some signal problems. Okay.
The role of non-invasive respiratory support, I think, is different in different patients, and also possible different types of non-invasive respiratory support. First of all, we are mainly using, at least in Italy, the helmet CPAP, so with the high flow CPAP. We don't use frequently in this phase high flow oxygen nasal cannulas, even if some centers they rarely use with some caution, but eventually only in the ICU. And we rarely use positive pressure non-invasive ventilation outside the ICU. So first message that we mainly use helmet CPAP. In which patient, with which target? I think we have two main targets. The first one is to try to treat patients outside the ICU and to understand if these patients can be intubated or not. And the second aim in case is as a palliative care in those patients who will not be intubated in order to reduce dyspnea according to palliative care. So what about the treatment? So we usually do a test in those patients who are progressively deteriorating. So we apply CPAP by helmet at FO2 60% with TIF around 10. And if the patient increased the saturation of oxygen higher than 95 and the respiratory rate below 28 breaths per minute, take this number like main threshold, these patients are maintained by helmet. This may be extremely helpful to also avoid the intubation. We estimate between around 20% of these patients, or 25%, may even avoid intubation, or eventually also eventually attest for intubation. In those patients in which this is applied, and the saturation is below 95 and respiratory rate or respiratory rate is above 28 breaths per minute, in these patients we intubate these patients if there are not main contraindications. So the use of non-invasive respiratory support, at least in our experience, is mainly by outside the ICU, is mainly by and those patients who can improve and those patients who eventually need intubation.
I see. And Paolo, will you talk about feasibility of some diagnostic tools during the treatment?
Yes, there are different new findings, I think, relatively new findings. We are using more and more the the monitoring of the coagulation of these patients, because as we will discuss eventually later, we found that these patients are very prone to be hypercoagulability. And so we measured, for example, twice a day the D-dimer in order to see this effect. The second point is that we use more and more the cardiac echo in all patients, because of course we found a major alteration of the heart, also related to the mechanical ventilation, and there are probably also some alteration in the myocardium with an increase in the troponin in some patients. And of course we use the lung echo, so echo play a very relevant role. And fourth, but eventually we can discuss later,
there are some signals
of CT scan of the lung that is giving us a major information. Of course, this has to be selected, I think, to those patients. Eventually, we can discuss later.
I see. And we are all wonder of your recommendation about ventilation setup, the use of prone position, and if there is any other possibility.
Yes, I mean, what we do actually, and I think is more or less as Giacomo showed as an average data, we found that almost all patients, when they are intubated, they appear with a very low PO2-FO2 ratio. So most of them, they are below 100 or even lower. And so at the beginning, we ventilate with a moderate high level of PEEP, between 13 to 15. But we try to reduce PEEP as fast as possible around the level that Giacomo showed. And then we ventilate with protected tidal volume in the first days, but the plateau pressure was not a major problem in most of cases, and so very good compliance. So plateau pressure not higher than 22, 23. And this, at the beginning, was associated to the use of prone position, but we don't use prone position, very much less than Giacomo showed 20%. I think we use less than 3%, because we found some major problems, not only organization, of course, we cannot prone all patients, and the second point that they can respond, but also we found an increase in the CO2 and some alteration in the respiratory system. So personally, we don't use prone position in these patients, and we try to go very, very fast to assisted ventilation when possible. So we reduce the neuromuscular blockade, we reduce the sedation, and while if you use prone position, you have to increase sedation into neuromuscular blockade. So I'm not recommending one strategy or the other. What we are doing actually is that after the first week, we follow it more these lines, so more sedation, and higher PEEP, and prone position. Now we are following less PEEP, less sedation, less prone position. And then we go to assisted ventilation, and this is the point, because we have some patients that progressively improve, some patients that they stay at that level. And in these patients, if they deteriorate, that's the point. We perform CT scan, angio-CT. Limited. When they deteriorate, after some first 3, 4, 5 days, when we are going to assisted, they have pulmonary embolism, and we treat it with thrombolysis, and eventually now I can tell you even after our point by using anticoagulation.
And that would be my next question, that we also recognize the very high value of D-dimer among our COVID-19 patients. And so can you give us a little bit more about the explanation and the strategy of anticoagulation, and how do you monitor it?
Yes, this is, I think, something new for us, and we recommended other people they found something before. Then they increase, other they stay stable, but this is also below 2,000, 3,000. and some maybe up to 20,000, 30,000. So what we do now, actually, is that we monitor the dimmer at least twice a day, and we monitor now coagulation also with rotten, and we found a huge embolus or microthrombosis, because now the model that we are building up that the fibrotic process by rotten tag. Now, in some patients, we go even up to 50,000. Of course, you have to take care about possible bleeding from the nearly the bladder, but there is not a major problem. But you have to modulate, I think, on this. And then we use also antiplatelets. Then, when we have the patient in the weaning phase, in some patients, especially those that had major thrombosis, we go to Coumadin. So, and then we discharge to a special area next to the ICU that we have. So, I think that the coagulation process is very important, and please take care of the fact that some patients may have microthrombosis or pulmonary embolism, which may be associated with a deterioration of the patient. If you do thrombolysis in this patient, they suddenly improve that. COVID-19 is a killer in the different parts of the lung. It's a killer for the lung, it's a killer for the heart, it's a killer for the hematic point of view.
And Paolo, you are the expert. Please tell us about the pathophysiology of novel coronavirus disease 2019. What are the hypotheses and what are the facts?
So, of course, we have to learn a lot about this. And but what we have found now, actually, is that we have different phenotypes. We are doing many CT scans. We are almost doing now, actually, around 25 CT scan patients every week. Because we are collecting a huge database for CT scan. And we are finding that we have these three phenotypes. So phenotypes, the three CT scan images. One is the more typical by COVID-19, so these gray areas around the lung, some peripheral, some in the middle, with not much edema. And we hypothesize that these patients, they have hyperperfusion in this area because that is relatively well aerated, but the shunt is very low. But when you apply PEEP, we found also, now we are doing also CT perfusion, that the blood is likely diverted in the area. So some of the response to PEEP that we observed are related not to the recruitment as usual, but is reduced likely to a redistribution of perfusion in this pattern. Then we have what we call phenotype 2, which is a mix between the conventional phenotype of COVID-19 and together with some on edema. So they are some more like RDS. So you can have atelectasis one side, no atelectasis on the other side, very dishomogeneous. And then you have a third phenotype, which is likely to be after 4 to 7 days. And that's why probably some patients, they remain stable or they deteriorate or they don't improve anymore. And this is the more typical than as like RDS. But you don't recognize almost anymore what is COVID-19. You have edema, you have atelectasis, and so this is a completely different pattern. So what we found is that there is a completely different pattern in the lung morphology. That's why I don't think we can have a recipe for ventilation for all of them. And so that's why I think that CT scan, when possible, is very important. We can use also echo lung, the lung of the ultrasound of the lung, but of course the information that you can get from CT is very important. I agree, of course, that we have so many. We have many patients. We have now actually more than 60 patients intubated in our hospital, in our unit. But of course, you don't do CT scan in all of them, but in those patients in which you believe that this can have a clinical importance.
I see. Paolo, superinfections among your patients, is it existing?
What we observed, and I don't know which is the experience of the others, because this is something that we are doing together with our infectivologists, is that when patients are coming, very few, they have or flu, because we test also for flu, or other superinfections first. But then, when we have the duration of the intubation for a longer period of time, so after, I can say 10 days, at that point, we are starting to observe superinfection. It is not in a large number of patients, I can say, and in most of cases are all MRSA or some gram-negative, but not multi-resistant. And this is important also to be considered when the patient is deteriorating. I think there are two main reasons. Two main reasons. One is that you are developing a lung superinfection, or you are developing microthrombosis or pulmonary embolism. So these two things has to be monitored. That's why PCT or PCR, and that is very important. With also the microbiological analysis is extremely important. So this is what we are observing. We are using, because we are doing both with our infectivologists, a coverage since the beginning with antibiotic, with cephalosporin against MRSA and gram-negative. So I know that this is not common in other centers, so it's possible that our relatively low rate of superinfection is also good, that there is a prophylaxis for that can be discussed. This was a choice in our patients.
I see. And do you use any pharmacological treatment? Because there are so many publications.
So I can tell you exactly, here we are going within an issue of infectivologists also, and we decided now we don't use anymore any antiviral, so we don't use any antiviral in the ICU. We just use hydroxychloroquine. This can be debated, of course, but this is actually our choice. And then we use, according to the amount of drug and its selected patient, but the tocilizumab, so the anti-rheumatoid tocilizumab, and we don't use actually, because is moving on, is the remdesivir, which is another possibility. But I can tell you that tocilizumab, now we have to see the data, and then we are waiting for more information. It is a drug that we are using in our patients together, and this is another debatable choice. We are using also corticosteroids. So we are using methylprednisolone 80 milligrams. 80 milligrams, so 1 milligram this is under debate. I can tell you that some patients markedly improve with methylprednisolone, other patients less. We have no evidence actually. We are looking at our first data. If there is higher superinfection, does not seem the case. So I'm not recommending anything. I'm just telling you what we are doing. I can tell you that we got some major improvement with tocilizumab and corticosteroids. But of course, this is open. These are the different choices that we have. And then we use nitric oxide if we want to be back also. In some patients, we have 3 machines, so of course we cannot do everywhere. And we got a quite positive response. But of course, this is for a limited period of time, just to see if you are going in one direction or the other. This is what we are actually doing according. And then we use cephalosporin against MRSA and gram-negative since the beginning in all the patients. There is a coverage. We don't use, on average, azithromycin. I tell you what we are doing, and only if you are allergic to cephalosporin as a These are not recommendations. It's just what we are doing in our unit according to our infectivologist.
I see. And how do you treat the patients after extubation? Do you have any special methodology?
This is another issue that was discussed also from organizational point of view. So first of all, when we extubate the patients, of course, we have a very large ICU. We have different ICU now, actually, on different floors. And we have some box, but of course, it's a minimal amount of box. So first concept, don't, in my opinion, take care if you have no boxes. Oh, this is a major issue. You have to consider the ICU like an open ICU because we have to deal with so many patients. Second point, we organized an area just next to the ICU dedicated to the patient that we extubate in the ICU, and then we keep for 1-2 days, and then we move to this area under our control, anesthesiology, intensive care physician control, and there we monitor this patient for at least 5 days before we discharge to the infectious disease. Because in that area, we can follow the thrombolytic because we see that these patients, if they are breathing normally at this point, the oxygenation is quite good, there's no need anymore of CPAP and so on. This looks like good, but we did the CT scan and the CT scan is not good. So we don't know if it's fibrosis, if again disease, whatever, but the CT scan of the patient that we extubate, and they are perfect, perfect, sitting on the bed, physiotherapy, no, it's not good. Probably, we hope it's good after months. Of course, this is only after 1 week, 10 days. The second, they are very thrombolytic, thrombophilic, even in that time. So you have to control the anticoagulation in that time before going out. What we do, so this is from organizational point of view. Why do we need that? Because we have the patient that we extubate, and we extubate, we do a test, we go as pressure support at 6 and PEEP of 6. If they maintain a good rapid shallow breathing and oxygenation and so on, we extubate, of course, under control, and then we extubate under double aspiration, so aspiration in the tube and aspiration in the pharynx in order, because there is a lot of secretion near to the cuff. So we do this the aspiration, and then we apply or helmet CPAP or also positive pressure by ventilator in the ICU. At this point, we keep these patients 24 hours, maximum 48 hours. If they need, of course, we follow, and then we use a Venturi, simple Venturi mask with surgical mask on. And then after 24 hours, we discharge to this unit that we open next to the ICU, and so we have the possibility to admit other patients. So this is what we do. Actually, we have no reintubation of the patient that we extubated. We are around actually of 30% of extubation, but of course the number are evolving. Because, this is what we are doing. And some patients we always do, and I recommend to do a swamp from the bronchoaspirate or BAL before mini bronchoaspirate, before extubation. So you have the swamp, but it's very important in the deep areas because there is a disconnection between the negative swamp and positive. And so this is very important to know when you are discharging the patient. And if I can conclude, I followed very interesting discussion before. If there were reinfection, and Giacomo mentioned the 2 patients that were, I think that some patients that are considered not cured because we have two negative swabs, in the reality they have a positive swab in the deeper areas. And of course, if you are extubated, you don't do that, or we have more difficulties. And so I think this is something to be considered. That we are very cautious also to get a swamp, a deep swamp before extubation to know at which point we are.
I see. It's very important. It's very important message. Paolo, thank you very much. And Marcelo, let's check the audience question.
Yes, Ilona. So, Paulo, you talked about the use of the CT scan. Can you elaborate a little bit more? Which are the consequences of the CT scan? So, based on the findings of the CT scan,
yes,
how can you tailor the mechanical ventilation, the decision for prone positioning?
Yes. So, first of all, we do the CT scan due to our technical organization to 2 levels of people. So, we don't do too high because we cannot do more than 2. So, we do 2 CT scans at 2 people. And now we are doing also perfusion CT scan, but this is mainly to look at what's going on for perfusion. But so we do at 2 pressure, and this is important because if you see a CT scan, what I call phenotype 1, so more typical of COVID-19, so no atelectasis, no edema like this, these patients, we maintain a moderate PEEP level, and eventually these patients are those who are responding much better to nitric oxide if they have a major more deterioration in oxygenation. In those patients, we have what we call type 2, so with some monolateral, so one lung is more like RDS, so with atelectasis, ground glass like this, and the other more COP. This patient, we do also some positions of the patient. While the third type, in some of these patients, we turn COP. So this is just to give you an example, or we are a little bit more aggressive in recruitment, or a little bit more aggressive in PEEP. So just to give you some example, why the CT scan can give you, first of all, some more ideas on how to tailor individually mechanical ventilation. And also it's very important to follow this patient, because if you develop a severe infection or you develop pulmonary embolism, this is very important also to associate angiotac. This is very important in my opinion, because angiotac gives you very important information on how is the distribution, and this is also have to be associated with echocardia and echolang, echocardia and angiotac. So that's why we have patients in which they have a pulmonary embolism that you are difficult to recognize, and this patient were improved just with thrombolysis. And so, and also how to better give and tailor the anticoagulant together with edema. So just to tell you that it's something that I think, I'm not saying that you have to do in all patients, because it's impossible. But in cases in which you don't see an improvement or you see a deterioration, the CT scan can give you more information. If you do early, of course, this can be also helpful to get information on how to better tailor in a more specific way mechanical ventilation and other respiratory supports.
Some other questions from the audience? Do you have any, Marcelo?
I do have some more questions to follow. Could you comment, please, on the approach that has been, let's say, suggested here by one of the attendees? So the use of the PEEP is either low, so something around 8 to 10, possibly the most patients will be ventilated with a PEEP lower than 15. This is a little bit different from CPR ARDS.
Yes, this is something is changing now, because at the beginning it seemed that from initial experience was recommended to use a bit higher PEEP, and even up to 18, 20. And when we look at this, the right atrium, especially if you are in the phenotype 1, so when you are more seeing the real poor COVID-19, the right ventricle is very much, so one has to take care of it higher than 50, because the right ventricle with normal lung compliance, normal good lung compliance is terrible for the right ventricle, and this which we hypothesize that may also promote the thrombosis because the flow is less. This is was an idea of our cardiologists. You have to be more conservative of it now. In some patients you cannot. This is true. That you have to use 13, 14, sometimes 15. But they improve oxygenation not due to the recruitment, but in the blood flow. So we have to know this. And so that if you have a deterioration, that's another point. When you are going back to PEEP, you have to understand if this is due to the conventional causes like attenuation, if it is due to solar infection, or pulmonary embolism, gross or micro pulmonary embolism. So that's why I think that the level of PEEP should not exceed the 15 in most of patients, and you have to go down with PEEP as much as possible, eventually by allowing a little bit higher level of FiO2. But take care, in my opinion, this was our experience in our 60 cases, that the pulmonary vessels play a major role in the gas exchange of these patients and their interpretation. So don't forget that there is also the vascular side together to the alveolar side.
Paolo, thank you very much. We would like to hear you for hours and hours. But and thank you for the audience for the questions. But Marcelo, let's talk about Germany. Germany had much time to prepare for the pandemic as compared with China and even Italy. Which lessons from those countries were the most important?
Thank you, Elon. So So we were able to learn from China first, maybe also South Korea and Italy. So Germany had time to know which the challenges that we have to face, and we to prepare. Regarding the preparation of ICU beds, because we saw that the number of beds were requiring in those countries could be far higher than the available beds that were there. So Germany is still preparing. So we are in the increasing, let's say, limb of the curve at this time. And at the same time, we are, let's say, improving the resources in terms of ICU beds and even devices.
I see. And as far as I know that for 100,000 inhabitants, you have 32 ICU beds in Germany. You have the highest number of ICU beds. Does this apply also to the number of physicians and nurses? What about your supplies, including ventilators, masks, ECMO devices? Can you talk about it?
This is a very good question. So even if we have probably the highest number of beds per 100,000 inhabitants in Europe, possibly worldwide, still there was the fear that that number could not be enough to face this epidemic or pandemic. So what we are trying to do at the same time is to, let's say, apply measures so for people to stay home, for avoiding social contact as far as possible in order not to, let's say, exceed the capacity that we have. In terms of the numbers of physicians and nurses, let's say if we increase the number of ICU beds we have, of course, we have to take other specialties as well. So gain people from other areas, for example, people coming from surgery with some experience also in intensive care, but also people that have not been, let's say, involved in care. Even students, they were being recruited, let's say, to give probably the first care for those patients who work on triage and so on and so forth. So the number of nurses, probably what will happen is that, so we live in Europe, in most countries in Europe, by shifting the focus from OR activity to ICU activity, this can be solved. Of course, so to make a predictions now is extremely difficult. So Germany is doing the best it can to solve and to avoid this kind of, let's say, of shortage of personnel. In terms of equipment, so it too much depend on, let's say, the ability of the industry to deliver the, let's say, the devices that we need. For now, so I don't see a big issue in terms of this. So mechanical ventilator seems to be, let's say, available here now. ECMO devices have one dedicated homepage, so a kind of registry where the German centers, they can enter which is the availability that they have. And I just took a look a couple of hours ago to see which is the availability of, for example, ECMO beds and ICU beds, and we are still, let's say, the epidemiology, the data that we have seen so far from Paolo, from Giacomo, and also from Tseng. We should not be feared about the shortage of ECMO devices right now.
I see. And may I have another question, that the mortality is so low in Germany, 0.3%. How do you explain it? What's the difference comparing to other countries? What do you do better?
Well, we can only speculate about this. So the numbers that we have from today is 0.5% mortality in those patients. So that Germany is testing much more, and are considered to be mild and moderate. And of course, so the severe cases are diluted in a matter of care, better care, but far it's not. Lona, do you have still questions to me?
Yes, I have to you that as far as I know that you are still preparing for the worst case in your department. Where is the focus of your effort now?
The caregivers that we have first in the anesthesiology department. So we are trying to, let's say, to make them familiar with the procedures that we have in the ICU. So this is a legal, let's say, issue as well, that thought about on how to use that device. So we are preparing the personnel, so we are changed the, let's say, the shift with this challenge that will come. The number of with tumors, emergency surgery, that the personnel can be still a little bit relieved now. You can, let's say, work with let's say later on, but in a short time frame for now.
I see. I hope that Marcelo is still hearing me, because I have one more question to you, that You have a very strong research profile. Is it possible to do research during this crisis? Are you aware of research initiatives dedicated to COVID-19?
Well, doing research that is non-essential is not possible anymore. So in our hospital, in our department, we stopped all, let's say, the persons that we had that were able or that they could, let's say, use resource that is needed somewhere else. Also, we were a little bit, let's say, concerned about more research. Possibly we would use material that could be, let's say, needed somewhere else, and we stopped this as well. Of course, so at least in our department, we have a strong, let's say, record in research with mechanical ventilation, all mechanical ventilators that we have used. So for research, for clinical research, they have been now, let's say, sent to the ICU, and they are, let's say, ready to be used there. Regarding the research with the COVID-19 and dedicated to this pandemic, there are some calls now we have from the German Ministry of Health. There is a call for submitting proposals. And as a matter of fact, our department, together with other departments in the hospital, is working right now on a proposal for treating those patients.
Thank you very much. Thank you, Marcelo. And indeed, there is too much to learn and to be aware. May I ask our presenters, first Giacomo, even though you had some take-home messages, can you repeat shortly to us for our audience?
A huge, or at least an increasing mismatch between the number of patients required in the ICU and the ICU bed capacity. So healthcare system should be prepared to increase their ICU bed capacity, to reorganize, and to to create a network of dedicated ICUs, or at least this is the model we have selected. The second message is that it's extremely important to train healthcare workers on the proper use of personal protective equipment, because working with PPEs is extremely tough, from physical, but also from. So it's very important that healthcare workers can, at least be confident that we are doing all the effort to reduce the risk that they can get the infection or transfer the infection to their families. And the third point, which is, I think, the most important point, is that if you experience an uncontained COVID-19 outbreak, no healthcare system, no matter how potent, how modern, how efficient it is, can deal with the incredible number of patients you are required to take care of. So we should do every effort to prepare the population that the most important measure is to avoid, the solution is not opening new ICU beds or keep buying ventilators. This is a good solution for people who already are sick. But the only way to survive to this, the only way to avoid that this becomes like a catastrophe, is to try to contain the spread of the disease. And the most important thing to contain the spread of the disease is to teach the population that have to be ready to change their behavior, at least for a period of their life. So this is, to me, it's very important. And this has been one of the major difficulties we had here in Italy, especially during the first 2 weeks of the outbreak.
Giacomo and Hua, what's your message, take-home message for us from China?
The first message I would like to mention is COVID-19 is the first message I would like to mention is it's extremely important for anesthesiologists and critical care physician to follow strict self-protection precautions. The second message is standard protection should be conducted when performing anesthesia in long-suspected patients because some of these patients are in incubation period without clinical manifestations. The third message is general anesthesia is recommended for patients with COVID-19, and spiral anesthesia is recommended for cesarean section in mother with COVID-19, and general anesthesia can be prepared as a backup for these patients. The last message I would like to mention is a video laryngoscope or fibroscope is recommended for emergency and tracheal intubations in patients with COVID-19. Thank you.
Well, thank you very much for your messages. And Paolo, about mechanical ventilation, the key elements, will you repeat?
Yes. That you have different lung phenotypes, so COVID-19 is not always the same in all the patients and develop differently. Vascular side is very important, more important than we thought at the beginning. Monitoring is essential by echocardio, lung echo, but also, as I told you, at least in the majority of patients, by CT scan and coagulation. Mechanical ventilation should be trade this data individually and not like a homogeneous disease, because COVID-19 is not an homogeneous disease as we believed before. So it's very important to optimize non-ventilatory and ventilatory therapy. Then COVID-19 is a double killer. It's a killer after extubation, but likely, now we are collecting more and more data, and I hope more join, but also after extubation. The story is likely not finished after extubation, as I told you, about the possible lung fibrosis, the alteration in the lung after extubation, and the problem in coagulation. And my final message is for overall that information also to the governmental authorities all over the world is very important, because may help avoiding it for the sake just for not scaring people may be extremely wrong, it may be extremely dangerous for everyone.
Thank you very much, Paolo, really. And Marcello, the final take-home message from you.
But we have to constructively be the bridge from both sides at the same time. So on one side, you have to reduce the number of cases, so you have to constrain the, let's say, the infection, screen of the infection, but on the other hand, so you have to prepare your department, you have to be sure that you have enough ICU beds and people trained to deal with those patients. So better you work also on this regard if you still have the time for this. Any other, let's say, non-essential service or non-essential activity, including, so the research, unfortunately, should be now reduced or absolutely postponed. So maybe that one exclusion or one exception for these would be research related to this type of patients, of course. And as long as, let's say, the results could be available still during the pandemic, we have to consider this. So when we try to plan those, let's say, those projects, so we have different possibilities. You have registries, this is important maybe for the future for us to understand if we have to face such a pandemic again. We have to be very careful with compassionate use studies when we are testing drugs or other procedures, so without a control group. So we have to be very careful on this because so there is one thing that we have always to, let's say, to use in our profession is, let's say, the maxim first, do no harm.
Thank you very much, Marcelo. And to our audience, do not forget that this is our first webinar on COVID-19. European Society of Anesthesiology is going to have the second webinar on COVID-19 very soon. May I ask you, Marcelo, as the scientific brain of this webinar, to have the final words?
Thank you. On behalf of the European Society of Anesthesiology, I thank you, Professor Grassetti, Dr. Tseng, Professor Bobek for the moderation, and Professor Pelosi for sharing their knowledge, the expertise, and the time. So in this difficult situation that we have, we hope that the things that you have said, all the messages that you had, will contribute to save lives across the world. And as Ilona said, this is only the first of a series of webinars. As long as new information is coming in, so we'll try as ESA to provide you with that information. Thank you so much. For those people that were not able to join because the number of participants, this webinar has been recorded and will be available on the homepage of the European Society of Anesthesiology. Thank you so much. And also thank you, of course, I almost forget this, to the whole team behind this webinar that has been organized with us this evening. Thanks so much.
Sì.
So the webinar is over for this time?
Yes, I think it's over.
We've learned a lot from your previous discussion with your peers. We have collected some questions from our viewers. Well, some questions may not belong to your area of expertise. I will select several of them. The first one is, what is the symptom of the COVID-19 patients? And what is the weakness of the coronavirus?
The patients with COVID-19.
Yes.
Yes.
Can we talk, Sonia?
Yes, you can.
Okay, Marcelo, we have to record your answer again because when you talk, when you move, when you touch the microphone, we lost your signal. So at this point, I want to say thank you, everybody. It was really good. You really did a good job. Thank you. The first one, we have a lot of participants. Sonia, can you share some of the information first?
I know we have over 1,000 participants. I don't know if we have more than that, so I'll be able to know that soon. Other than the issue with Marcelo's microphone, it went very, very well, smoothly. Everyone's connection was perfect, and I think the on-demand version of this recording will be just amazing. So thank you very, very much for everything.
Yeah, and I'm sorry. We prepared a whole crisis management, but we forgot overloaded participants. I'm sorry for
And
that.
Practice 3 website as well. Yeah.
The website of my ESA, the login, I think they have more than 600 people logging at the same time. It crashed.
It all crashed.
I understand.
So
My colleagues, they could not join. They sent me messages.
I am so sorry.
I don't know what went wrong with the microphone because when I was, let's say, to become active, I switched it on. And this was the problem.
The problem was when you moved something or like touched the microphone. So it was, at some point, it just stopped.
Okay, I think at this moment we will let everybody go, but Marcelo, you stay because JB want to record your voice. So, but thank you, really thank you for everyone. You really did a great job.
Thank you very much.
Thank you very much.
Thank you so much.
Yeah, I know I want to say something.
I haven't seen anything from the chat, guys. Nothing.
There was the two bar on the top.
I was waiting for the ring. I could see nothing from the chat. So by WhatsApp, I was communicating with Annie.
But we will edit the first part, the dead air part, so nobody will see it except us. Nobody knows it. The 3,000 participants, they know nothing.
And when I heard Marcelo, he started, I said, it's starting time, because I could not, there has to be done something with the chat, the letters or the light of it or whatever, because I could not see anything. But thank you very much.
Yeah.
Bye bye everyone. Bye bye.
Bye-bye.
Thank you very much.
Good luck with your work. Good luck with your work.
Good luck. Marcelo, wait. Sonia, how are we going to handle with Marcelo?
Okay, so I don't know exactly what question.
We will repeat the 5 questions. Marcelo, can you just, do you have the
So, Dr. Zheng, can we continue to finish the question from our viewer, which is what is the symptom of the COVID-19 patient and what is the weakness of this virus?
The symptom of patients with COVID-19, the first patients is normally a fever, and some patients may have dry cough, and in some cases the patients may have runny nose, diarrhea, or some other symptoms. Yeah, I think the fever is the most popular symptoms of patients in patients of COVID-19.
So are there any weaknesses of this deadly virus?
Yeah, this virus is sensitive to heat and sensitive to, for example, we normally use 75% alcohol to make disinfection. Yeah.
Okay. Thank you so much, Dr. Zheng, for your insight. Thank you so much for joining us. For our viewers, CT team will provide more episodes of this special program, COVID-19 Frontline, in the coming days. Thank you so much for watching. See you next time.